can do it. But you know what? Doctors aren't doing it. They haven't been trained in medical school. Nurses haven't been trained in nursing school. Pharmacists haven't been trained. And it's a complicated thing to get this done. And there are codes on state Medicaid. Most states haven't turned those codes on. There's been great disinterest. Oh, that's not fair, you say. We're an illness too. We should be screened just like everybody else. Yeah, that's true. But that's not the main reason. The main reason to do this, even though it's going to be wonderful for substance use, to reduce the prevalence of substance use, the main reason is to reduce health costs. Substance use, even some sub-diagnostic levels of substance use, is one of the main factors complicating the diagnosis, course, management, costs, outcomes of every other chronic illness there is. Diabetes, hypertension, asthma, chronic pain, even tooth decay, all complicated by undiagnosed, unrecognized substance use problems. In the state of Washington, for example, they did this in their own, in 8 hospitals that were primarily Medicaid funded. And they just did simple screening and brief interventions. But by this I mean a doctor or a nurse or a counselor sitting down and saying, you know, Bill, you say you're drinking 5 times a week, and 3 of those times you're drinking more than 5 drinks. You know, that's too much. No, I'm not saying you're an alcoholic, but that's too much. And here I am trying to treat your hypertension, and it's not working. Are you going to need any help reducing your alcohol drug use? That simple kind of conversation saved $8 million a year just in healthcare costs. So, in the President's drug control strategy, we have asked for simplification of the codes, much less paperwork, and higher pay to do screening brief interventions. Okay? Okay. Now again, moving up the pyramid. Now we're talking about treatment. Well, have there been any? This is one of the kinds of things I get asked all the time. Does anything work in addiction treatment? Almost every social worker says, well, we don't have any treatments for addiction, do we? But treatment they need. Behavioral therapy. Almost every doctor says to me, we don't have any treatments for addiction, do we? By treatment, they mean medications. So, first, do we have anything that works? And by the way, what do you mean work? Well, we have the safest medications in the world. And if you want to get a medication approved, it has to be safe and effective. And that is shown by randomized controlled trials, large-scale trials. You have to have 2 of them. And the new medication or the new medical device has to be better than placebo or better than standard care in both of them. Okay? Here are therapies, just some of the therapies that have shown that level of effect. That's FDA level effectiveness. Okay? I'll tell you another thing about this. Every one of them has a manual. You've paid for every one of these because they've been developed with federal government. There's a manual, there's a treatment package. You probably learned about some of them here in your coursework. Okay? I'll tell you something else about it. All of them. They're free, and all that. And here's the other thing. They're almost not used anywhere in the addiction treatment system. Very few programs do any of these. What? How can that be? Hold on. You keep talking about this being a medical field. So do we have any medications? Yep, we got medications too. You all know about tobacco medications, nicotine replacement therapy, Chantix or varenicline here is another one. And it turns out, by the way, just came from a research setting, you combine those, you get more than twice the effect. We also have FDA-approved medications for the treatment of alcohol and opiate dependence. They work they work very well. They reduce craving, they reduce withdrawal, they maintain people symptom-free. Several of these, like buprenorphine, can be used in a primary care doctor's office. Okay? We have, in the treatment of cocaine abuse, we have, you don't have anything that is FDA approved so that your doctor can use it today. Topiramate you probably could use. Topamax is the trade name of that. But one of the things, but there are at least 2 randomized controlled trials of these medications showing that they are effective. That it doesn't, cure, doesn't eliminate, but is very helpful in the treatment of cocaine dependence. I put special emphasis here on vaccines. There are now 3 vaccine studies that have been shown. No, they're not preventive vaccines. You wouldn't give a 10-year-old kid this kind of vaccine, but you would give a 30-year-old guy or gal who's struggling with cocaine a vaccine. It's a single shot, and it works in a competitive way that if a person uses cocaine, the antibodies absorb it right away and prevent the cocaine molecules from reaching the receptors.
Wow.
You never feel it. There's still an experimental trial, but it's not very far away. We're going to have, within 2 to 3 years, we're going to have nicotine, an amphetamine, and a cocaine vaccine. It's very exciting stuff.
That's nuts.
We do not yet have anything for the treatment of marijuana, any medication for the treatment of marijuana or methamphetamine yet. Lots of work going on. We ain't got nothing yet. But everything above that box does work, is available, is not expensive, and is not being used. Practically no treatment program is using the buprenorphine as an exception. So wait a minute. So we got effective behavioral therapies which they're not used. And we have effective medications that they're not used. What's going on here? Here's what's going on. Addiction. Now we're up at the top of that pyramid, right? Remember that little tiny pinnacle up there? That's the number of people that are getting care. Where are they getting this care? They're getting it in specialty care treatment programs, which there are now about 12,000 of. At one time there were 18,000. Now they're around 12. Most of them are very small. Mom and pop shops. About a third of them treat less than 200 patients in a year. Very, very small. Point here is they don't have the resources to get into the game of upgrading lots of these new things. About 2/5 do not have a doctor as part of their treatment program. Most addiction treatment programs are outpatient, by the way. Okay? And about 2/5 don't have a doctor or a nurse. Yeah, that's fine, Tom, but I don't really see why that's important. Well, remember those medications I just put up? Who's going to prescribe them? Here's another thing. What pharmaceutical company wants to get actively involved in the creation of new medications if they don't have any doctors that are able to prescribe any of the stuff that they make? The market sucks in addiction treatment. They don't want to get into it. 75% of treatment programs in the country don't have a trained psychologist, social worker, psychiatric nurse. Point, remember those behavioral therapies? Most of those require training, advanced training. They're sophisticated, and they're not available.